via Vova. Three very well-respected practitioners working exclusively in the public sector in various parts of the country. So they're going to share with us their experiences and allow us to interact and ask questions. Some housekeeping rules for tonight. We are going to basically only use the Q&A to raise questions. Attendees are required not to raise hands as these are not monitored. Ask through the Q&A option and we will answer them either live or in person. Any questions that are not able to be answered or not within the domain of this presentation will be forwarded to head office and will be answered in due course and probably placed on our website. The number of CPD points for this event is 1 CPD point. To qualify for this CPD point, one has to just attend the webinar. There are no forms to fill, no questions to answer. Also tonight, this presentation is being simultaneously presented on YouTube, the South African Dental Association YouTube channel. So for colleagues that are unable to join via Zoom, they are welcome to join on YouTube, and this will be also posted permanently on the YouTube channel. So without further ado, I'm going to hand over to our first speaker or presenter for the evening, Dr. Karl Potgieter.
Thanks, Dr. Osman. Good evening, everybody. Yeah, I'm really excited to be able to have this webinar. I've got a little presentation that I want us to run through. So I'm just going to put it up here, and then we can go through it. Okay, to the beginning. Right, is the presentation up? Can everybody see? All right, so we all know about COVID-19, and it has posed really, I think, many challenges to all of us, our colleagues in the private sector, as well as for ourselves working in the public sector. And sometimes I think in the public sector we need some guidance that we don't really have due to many factors. So the specific risk that COVID-19 is posing to us, especially in the public sector, revolves basically around four things. The first one is the close personal contact that we have with our patients. I mean, we're sitting in a position where we work about 25-30 centimeters from their mouths, which is not the ideal place you would want to be for an upper respiratory tract infection. So close personal contact is the one. The other big risk to us is the repeated use of instruments. None of our instruments is basically once off that we use. So the repeated use poses many challenges in terms of cleaning and sterilizing and all of that, especially in COVID-19 now. Then the other thing is the number of surfaces that's exposed to the virus. I mean, from the patient enters a dental clinic, it's the door handle would be the first one. And then all the surfaces. I mean, if a patient comes in and he sneezes or so, it sprays droplets all over the place. And as you can see on that picture, there are cabinets, it's the spittoon, it's the delivery unit, it's the chair itself. So quite a number of surfaces that is exposed to the virus, and obviously by implication will need to have to be cleaned before the next patient comes in. And then I think our biggest threat obviously is the aerosol generation of most of the procedures, or many of the procedures that we do. So these are the main issues that I think puts dentistry and oral health in a high risk category in terms of COVID-19. So obviously the goal would be for us is to provide safe and effective oral health services. So that's what we're all aiming at. But when we say that, we mean safety obviously to ourselves, the oral health team, but then also to our patients, as they can also contact it at the clinic, and we don't really want that. But then I think most important in terms of COVID-19 is parents and families at home. We don't want to take it from a clinic and take it back to the house and infect your granny or your elderlies at home with comorbidities, because we've seen that they are the most vulnerable in society when it comes to COVID-19. So we don't really want to take it home, and that goes both ways. It's for us not to take it home, to contract it at the workplace and taking it home to our families, and also for the patients not to contract it at the workplace when they come for a service and then take it home to their families. So in order to mitigate this, I think there are 4 basic principles that we need to adhere to in order to see how we can mostly prevent this from happening. The first principle that I want to talk about, I'll just briefly go over, is the one of PPE and clear safety standards in the clinics. It doesn't really help if there is PPE available, but we never had any training on how the donning and doffing procedures work. So the PPE goes hand in hand with safety standards at the clinics as well. And obviously, that would be something that the workplace must provide. I think when you're in private practice, you procure all this stuff yourself. But for us in government, it's not that simple. There's a whole procurement process that we need to go through. And actually, it's a responsibility of the workplace to ensure the proper PPE and also that there are safety standards in place at the workplace. I mean, we don't work in solo. We are part of clinics. The clinics is part of a hospital sometimes, or part of a bigger CDC, a community day center, or something like that. So we're part of a big system, and the system also has responsibilities towards creating a safe environment. The second principle will obviously be the one of aerosol generation. So during COVID, I mean, SODA has had many discussions on this as well, and the levels of risk and when are you supposed to do aerosol generation. I think in private practice, this is a really big issue. For us, I would say in government sector in general, it's not that a big issue. I think our main thing would be is mostly got to do with pain relief. So we can scale down on aerosol generations in the public sector. Then the third principle would be the one of social distancing, including mask wearing. So obviously we know that it's 1.5 to 2 meters that we need to keep apart at all times. And one must also remember it includes us as well, the staff. So I mean, if there are 2 surgeries in a clinic and there are 6 personnel, one I think need to really have a look and see if that is the best scenario to be in. But social distancing, and obviously for the patients coming in, because I've spoken to people who say no, they maintain their social distance in the waiting area, but when you go just open the door where the patients wait to come in, they're all clocked up together. So that really doesn't make sense if the patients stand next to each other just at the entrance to the clinic, and then when they come in, now we want to keep them apart, but when they go out again, just outside of the door, there's a bunch of people standing there. So those are the challenges that we are facing. The fourth principle, I think, would be the one where we need to distinguish between what's routine dental care, what's been seen as urgent dental care, and emergency dental care. I think in the public sector, this is really a big discussion point to me, because I've spoken to some dentists who say, no, they're only doing emergency patients. But then in reality, all that they are doing is they're just not making appointments. They're doing walk-ins. So I think there's a really big difference between doing emergency services and just walk-ins. So per definition, that is a definition of the American Dental Association. The true dental emergencies are only things that is life-threatening, and that's got to do with like the picture, Ludwig's angina, cellulitis, that can compromise the airway, when there's facial fractures, trauma that compromises the airway, and then uncontrolled bleeding. But I'm not talking about you just extracted one tooth and now the patient is complaining about a blood taste in the mouth. It's really uncontrolled bleeding. So for true dental emergencies, it's life-threatening would be the definition. Then I think what we mostly refer to when we talk about emergencies is urgent dental care, which would be the middle one, the guy with pain. That's what we mostly treat. I mean, the true emergency ends up with a maxillofacial surgeon at the tertiary hospital or something like that. It's really at the clinic. It might differ in provinces that have clinics in the hospitals, But so for us in the Western Cape, our clinics is not in the hospital, so we don't really see that. Those people obviously go to the hospital firstly. And then routine dental care. So for us, to me, in the public sector, our whole issue during the COVID-19 is how do we scale up and down through providing routine care versus urgent care versus emergency care. And then obviously community outreach and all those things in terms of this discussion would fall under routine dental care, which would be the last thing that, or the first thing that we're not going to do. So the whole issue to me is up and down scaling between these ones. Do we only do emergencies at the hospital? Are we opening up urgent dental care clinics? And then obviously if it's a level 1, when we move back to level 1, we would start doing routine dentistry again, where we can do scalar polishes and things that's really, really routine. So I think this slide actually correlates quite well to the level that risk levels that Sada also has spoken about, level 1, 2, 3, or 4. And obviously one must remember, as your level increases in the sub-district where you work in, you would downscale your services. So for instance, it might not be the same in the sub-district where I work as in a sub-district next to me, which might not have a high COVID caseload and stuff like that. So that's the things that we need to talk about is how do we up and down scale and how do we rationalize that. So those are the 4 principles I think that we need to keep in mind. Then the next thing is like I say, the up and down scaling of services. So there are 2 questions. It's when do we upscale, when do we downscale, and then how do we do it? So to answer that, I think in terms of when do we up and down scaling, would be there's a need for discussions to be had between the sub-district management and the oral health team. Like I said, we are not in a situation in government. I mean, you all know that. We all have supervisors, line management. There's some other manager that you must report to. You can't really do just as you please in the clinic. So we need to have a discussion between the oral health teams and the sub-district management. And at these discussions, in terms of what services we would render, I think the important things to keep in mind is the number of COVID cases that one has in the specific sub-district, the daily new cases, daily recoveries, COVID-associated deaths, which are COVID hotspots or not, and reallocation of oral health staff, and then physical space at the clinics. And all of this has got to do with I almost want to say the worseness of the COVID in your sub-district. I mean, if we are entering a phase where in the sub-district where I'm working in, we are closing in on 1,000 cases now. I think within the next day or 2, that's cumulative now. But still, so it's really a hotspot area. In terms of the Western Cape, it's also now being recognized as a hotspot area. So one wouldn't really downscale on services at the moment. But I mean, in about 2 or 3 or 4 weeks' time, it might look different. And these are the sort of indicators that we will look at. How many new daily cases do we have? How many recoveries? How many deaths? Is there new hotspots developing? Right? I think it's fair to say that Gauteng will be the next hotspot now. In terms of provinces, it used to be Western Cape, but Gauteng is now overtaking us. So that's the type of things that one will need to look at and keep in mind when you want to decide on which services you must render. And you must the other important thing for us is our managers are mostly not oral health related people. So it's up for us actually to get into discussions and talks with them and state our case. I guess there might be non-oral health managers who just say, no, it's business as usual. And I'm perplexed by that. I actually spoke to a dentist the other day, and their managers just say it's business like as usual. That's why I think this topic of business as unusual is really relevant, because it is not business as usual. I don't think we can say that, but we've got a responsibility from our side also to talk to our management and tell them these sort of things. So when you decide now, we are going to render whatever level of service, I think the next question is, how do you do it? What's the factors that come into play into the how? And that will be stuff like this, these staff considerations, because obviously we are part of a big organization. There's always labor issues, unions and so on that goes around. So there's staff considerations that we need to keep in mind. And then there's patient considerations, and I'm going to go into that into a little bit detail now. And then dental clinic considerations. Then obviously there's a certain practical protocol that needs to be in place, and I think that's something that's lacking in most dental clinics. That there's no really guidance or practical protocols. So when you enter there, I've worked in many dental clinics, public dental clinics, and in most of them, when I entered on day one, it was just, we basically do extractions, and if you want to do something else, you can do it. So there are some practical protocols I feel needs to be in place as well. So I think most of the how relates to how do we create a safe work environment, and I mean safe in terms of COVID, because it is a reality. So how do we create a safe work environment in the COVID times? And then these are the type of things that one will need to consider and discuss with your management. You also have to, the staff factors now, if you look at the staff, you'll have to look at the availability of staff. I think Dr. Mohammed will agree to me that in many of the hotspot areas, many of the oral health staff has been reallocated to help in the COVID response. It's the same in our sub-district. So you must have a look at the availability of staff, and then obviously the availability of PPE. I've spoken to someone else who also informed me that she had to buy her own PPE to use in the clinics, and then I mean that's a responsibility of the workplace to ensure that the PPE is available. And then training of staff, like I said, doesn't help. They just put the PPE down there, but no one tells you how the donning and doffing procedure works. So we need to be trained also on how to don and doff the PPEs. And then obviously staff screenings. In government, while I work, we need to be screened every morning when we go into work, and that's being kept in a file. And then also work scheduling. I think if you're in a hotspot area, you should have a rotation of staff where, and I know there's many different interpretations of that, but I just feel in terms of keeping everyone safe and keeping social distancing in mind, it's not a bad idea if there's maybe 2 surgeries to keep the one surgery as your donning and doffing area, and you only work in the other surgery, or work in the one surgery today and tomorrow work in the other surgery, to give the one time to rest. But I think one can work out a work schedule that will create a safer environment to everybody involved. Then when we get to patient factors, it's obviously social distancing. So make sure that the patients, because I mean we need to protect the patients as well. So we need to make sure that they keep their social distance in the waiting area before they enter the clinics, and then that the patients are being screened before they get into the clinic. Usually at the clinics, though, they are being screened nowadays, the patients, before they get into the clinic. But I also know of clinics where the patients just walk in from the street and they're not being screened. They keep the social distance to some extent, but they're not being screened. So we need to do that as well. And then obviously the patients wear cloth masks when they go into that area. And then, I mean, an appointment system would be helpful. Because the problem, and that's a problem I'm foreseeing for us when we start to downscale again and go into opening up for extractions, is that we might get a big rush of patients coming to the clinic, and that will compromise on social distancing and all those measures. So then the dental clinic this has got to do with the physical space at the clinic. Is there physical space? So in terms of how many patients can you safely seat in your waiting area by still keeping the distance? And that's the type of stuff that we also need to think about in the patient flow. Will the patients know where to go, where to sit? How do they enter? How do they exit? Where can they touch? Where don't they touch? And like I said, donning and doffing, is there donning and doffing area at the clinic? And then another thing is ventilation. Now, I think we all agree in the Western Cape, we are quite aware of that with our TV. So just make sure that there's enough ventilation, normal ventilation. The best is to open the window. And then waste removal. I don't think one would like to have COVID waste sitting in a surgery for 3 or 4 days before it's being removed, and you still see patients the next day with yesterday's and 2 days ago's waste still being there. And then, like I said, the practical clinical protocols. I think from our side, we need to start getting that in place to present to our management as well. So I'm getting to the end now. In terms of responsibilities, because I feel there's some responsibilities that is up for us as the oral healthcare team, but there are also some responsibilities that's the responsibilities of the workplace. So again,
it's the oral healthcare team on the one side and the sub-district management or the management structures on the other side. And just to quickly summarize that, yeah, I think to adhere to those basic principles that we talked in the beginning, which is clear and
safety standards, PPEs, aerosol productions to be kept to a minimum, social distancing, and then saying where we are in the up and down scaling of the services that we render, that we need to keep to those principles. That's going to be our responsibility. And I think if the management put any requests on us, if it's a reasonable request, obviously we all go for it. But then we might get in situations where there's unreasonable requests. And I think in terms of COVID, an unreasonable request, in my opinion, would be if a manager tells you to work and now you're in the COVID hotspot and they're not providing PPEs and they say no, a surgical mask is enough. So then I think it's our responsibility to stand up and say, listen, this is not a safe work environment. This is compromising on the basic principles that we need to adhere to. So from our side, we will have to adhere to those principles. From management side, I think it's really important that they are the ones who should be able to, who should create a safe working environment for us. I mean, the procurement processes for PPEs and so on will go through them, but in discussion with the oral health team. And then from our side, again, I think we need to monitor the situation. And I think that's basically what we are also, why we are having this webinar, is because we have been monitoring the whole COVID response, and there's some questions that needs to be asked now. So from our side, the responsibilities would be to monitor the situation, adhere to the basic principles, and then have a discussion with the management all the time, so that they can create a safe work environment. Because I really don't think they can ask us to practice if the PPE and the safety standards are not in place from their side. So there are definitely responsibilities on both sides, from management and from us, and we need to be in discussion with our management in the sub districts to see how we can go around this our response. So
the last slide.
The summary, I would say it is definitely not business as usual, and I don't think we should accept if a sub district management tells us no, it's business as usual. I don't think we can accept that. I don't think that's a reasonable request from their side. And there are many factors to consider in terms of how we get to our response, because we need to be able to rationalize what we are doing. I mean, if we move up or down that scale of routine versus urgent versus emergency care, I think we need to have the rationale behind it, why we feel a certain way, why we feel we're only going to give pain medication at the moment, or why we feel no, we can start with this, or we can start downscaling a little bit. We need to have some sort of evidence behind us, and behind our reasoning. And then I think the most important, what it all boils down to, is that we need to engage in discussion with our management at the workplace, and really so that they can understand the whole issues that we're having in oral health, and why we, like I say, if we say no, but we feel we're only going to provide this level of care, we need to be able to tell them exactly why, and then come to an agreement. Because I mean, it's not going to be helpful to get in a confrontation with your management, but we definitely need to communicate properly with them and clear out the roles, responsibilities, and why we feel a certain way and why they feel another way. I really think that's the bottom line of all of it, right? And that's my presentation.
Thank you, Dr. Potgieter. I trust everyone is got quite a bit of information from that presentation. I'm just going to ask participants once again, please try not to raise your hand on Zoom. It would be appreciated if you could submit questions via the Q&A. I'm going to give a few minutes for attendees to post questions, and the panelists will then answer. I think Dr. Potgieter, Dr. Mansoor, and Dr. Vova How does a dentist in public service escalate a problem like refusal of management to provide proper PPE?
Dr. Osman, if I can get into that, I would feel that they can't refuse to provide PPEs. I think it's against labor law, because I'm sure every employer in South Africa has the responsibility to create a safe work environment to the employees. I mean, that's an area where one really doesn't want to go into. But if my management would expect from me to work now without them providing the PPEs, I will really sit down with them and just tell them, listen, guys, I think it's unreasonable from your side. You can't do that. I really don't think we should settle for that. But I mean, there are ways and ways to go about it. I don't think we should get confrontational, but I really do not think that they will get away, that we can accept that. And I just think you don't really want to use the word labor law when you speak to your management every day. But I think this is unusual circumstances. And I really think that in this case, I would tell them if they really refuse and they expect me, I would say it's an unreasonable request. And I'm pretty sure it's against labor law or labor practices, sound labor practices.
Thank you, Dr. Potgieter. One of the other panelists would like to add?
Hi, good evening. So from my side, in the Cape Town Metro, am I on? So we have got lots of circulars. It's quite laborious. And the thing is, most of these circulars do highlight if there are concerns of staff members regarding any unfair, so to say, labor practices. So then I would classify this under that. Currently in our Metro district, we have weekly engagements with labor. Our directors will be notified of such issues if they were to come from the staff. So there's even our HOD of the department, he's got a WhatsApp line. So these type of issues, although it's every day, it needs to be sorted out at the moment. There are different line management structures that are in place. I'm not too sure on the different provinces, but within Cape Town Metro, there is that provision. I know previously labor issues they took quite long to be sorted out. And with COVID-19, the engagement is much more regular and the opportunity to raise these concerns are much more free. Yeah.
Thank you, Dr. Mohammed. Is it correct to also assume that most institutions or clinics will have a designated compliance officer or someone who's in charge of OHS? Would that not be an avenue to perhaps pursue if managers don't want to provide PPE?
Dr. Osman, can everybody hear me?
Yeah.
Dr. Vova, just move a little bit closer to the mic.
All right.
You're a bit faint. Thank you.
Is that much better?
Yes, much better.
Lovely. Just to actually chip in a little bit on the issue of labor issues and how basically, for example, to answer your question regarding whether or not there would be a labor compliance officer available. Well, as far as I know, there should be in place at all respective facilities, but it would be very difficult for small clinics, for example, to be able to have one on site, and perhaps you would find that they would be based at a sub-district office instead. But in district hospitals, regional hospitals, and other higher level hospitals or institutions, there should be a labor officer. However, again, when one deals with labor matters of this nature, it would be very much important that they first start with the employee supervisor relationship and move on that basis before involve the labor relations officer. Normally, the labor relations officer is there for two things: to offer advice, and also then he's often involved in more formal proceedings. But I would really urge that we don't get formal proceedings, but rather be able to get to a place where practitioner and management meets each other in the middle and are able to come up with a solution for any respective problem, including, for example, the one that is currently on everybody's lip, which is the issue of working with limited or actually no PE at all?
Thank you very much, Dr. Vova. All right. I'm going to go through the questions again, see if there's anything that we haven't covered. I see there's a question from Dr. Cronje that was dismissed. Dr. Cronje, your question was dismissed as it relates to movement of staff from different high up and down scale areas. Unfortunately, this discussion does not speak on behalf of government and how they intend to do this scaling. I assume it will be under provincial or regional borders. So we're not in the question to answer this. Therefore, it has been dismissed. We will refer it, however, to head office and see if we can seek clarity on that. All right. Then we have another question. With regards to PPE, would it be acceptable for management to make staff use the same basic PPE for a week or more? That being a disposable gown being used for a week or sometimes more at a time. PPE obviously has to be used. It's something that needs to be used within the guidelines as described by the manufacturer. So again, if it's not going to be allowed, if proper PPE, meaning the proper rotation of PPE is not applied, it would then also be something that needs to be reported or to be taken up with management. Because whether you've got PPE for a week and whether you've got PPE every day, the fact is the PPE must be there to prevent cross-contamination and cross-infection. So I think that question also has partly been dealt with by the three panelists. What are the implications if your clinic has got very inadequate ventilation? In that sense, that would have to be taken up with the public works department within that clinic. Well, obviously through your line manager, the facility manager, then they would actually have to make arrangements to get proper ventilation sorted for that clinic. But I think that would be also something that would be taken through the proper governmental departments involved. I don't see any other questions. I think we can move on to Dr. Mohammed. Sorry, Dr. Vova, you can come in.
Can I just quickly come in on the issue of raising infrastructure challenges, given, for example, responding to a question on ventilation? I think for many, many clinics around the country, this is a reality. Whether or not a person is actually working in a converted doctor's consultation room in an OPD, or actually has a standalone dental facility within a hospital environment. It is very much important for people to understand their own institution's HR structure and who it is certain issues can be raised to. For example, in a regional facility, you should have artisans in place looking after three functions, that is mechanical, building, and I think electrical. And each and every issue, for example, this one regarding ventilation would be escalated to the respective artisan who would be building to actually respond to. In some bigger facilities, there's actually a budget to make small amendments to the facility or to the unit in order to improve on things like ventilation. Where clinics or smaller facilities, again, this function will be then centralized within the sub-district office or LSA.
Thank you, Dr. Vova. Moving on, I think we are now ready for Dr. Mohammed to give his presentation.
Okay.
All yours, Dr. Mohammed.
Okay, so, all right. Okay, good evening, everyone. So look, first of all, I'd like to say thank you for SADA for allowing us or allowing myself this platform. I think it's the first of any type of conversation that has happened. I'm going to be presenting. It's quite a laborious, long presentation. I think that when we get overexcited and we want to share as much information when we have a platform where we have so much viewers and such a, can you hear me? And such a influential entity allowing us to speak. So basically, sorry, I just need to close this here. All right, so sorry, I'm not able to show my screen. Stop share. Sorry for this, I just need to close. Q&A. Sorry, 1 second. Sorry, this is technology, unfortunately. So I'm not able to close the Q&A session here.
Just minimize it, Dr. Mohammed. Just minimize it.
That's why I'm trying to.
And
it doesn't allow me to.
okay,
So
you can continue. You can continue. We don't see your Q&A. We just see the full screen.
So it's not showing. It's showing on my side now. I'm not able to cover my. How do I minimize it now? Not able to. So I can't see my screen because of the unable to minimize it.
Exit screen share and then try and do it, and then we can start. Dr. Vova, do you have a presentation as well?
So I can't show it. Okay, wait, so if I share, just hold on. It's not able to, it's not closing my Q&A. Okay, there we go. Okay, so sorry for that, eh? Okay.
Thank you.
Okay, so I'll continue. So basically the presentation is quite a long presentation. It's a representation of the Metro Oral Health Forum, which is established in the Western Cape Metro. It consists of various groups of individuals in the oral healthcare, and it's dentists, oral hygienists, and dental assistants. So it's kind of a situation analysis, and then there are various aspects of. Basically, we know a lot of information coming forward, and we've listened to many guidance protocols. But what is the strategic framework from the national and provincial that we should maybe be applying within our workplace, that we can kind of carry on doing what we need to within the framework and align ourselves? And so we've taken that aspect of presenting an oral health service which is kind of safe and protected. Okay, so all right, so basically I'll be reading off. The Western Cape Department of Health is committed to supporting a efficient standardized package of dental care to patients during the pandemic. Okay, so I've explained the PowerPoint, and it's made up into Part A, Part B, and Part C. Part A, basically just an introduction of how SARS, the COVID-19 has entered the Metro Health system and what response we've had. What are the different occupational health and safety frameworks that are available for us to practice, the IPC guidance, and then any clinical service guidance that can be, and then just an audit report of the clinic where I'm working at. Okay, so Part A. So what are the national oral health strategies that were there prior to COVID-19? So by identifying the different strategies that we were employing prior to COVID-19, we're kind of coming up with a plan that is supposed to be linked to what we're expecting to be the common conditions presenting to the dental clinic. So we talk about early childhood caries, the bleeding gums, loose teeth. These are the everyday extractions remains the most important modality of treatment. We're talking about linking our services to the national norms and standards so we can have a basic service, national health insurance, in December 2015, where we can have once again at primary healthcare that we are able to offer a basic service. And then the strategic plan for prevention, for the prevention and control of non-communicable disease, where oral health is now involved there. Okay, and then in the Western Cape, the strategies, so the last guidance we had was in 2010, and it's a comprehensive oral health service plan that we implemented. And just to summarize it, dental caries was the predominant oral condition that we had to treat. Gingivitis and calculus.
Sorry, Dr. Mohammed.
Yeah.
So I'm just going to interrupt you a little bit. I think the slideshow is not moving on the viewership. See, we're still stuck on the first slide.
Okay, and if I do that, left and right?
Nope.
Okay, should I quickly exit and retry? Okay, if I do that.
No, it's not moving.
Okay, let's go to exit.
I think exit again and start again, yeah.
Okay, anything happening?
Now it's on the strategy page.
Anything happening there?
No, it doesn't move.
Okay, so I'm moving left and right and it's still not moving.
No.
If I do that,
Now we're on part A.
moving. Anything happening?
No, it's not moving. Okay, I think just use your desktop without maximizing it. Or just if you could email it to Noma, then Noma will PowerPoint it from the head office.
Okay. Is there anything happening there?
We're on the implications for oral health service slide.
Okay. Okay, if I move, something happening?
No, it's not moving.
Do that. Anything happening?
No. But anyway, carry on with the presentation. We will try and make the slides available afterwards.
Okay, sorry for that, man. Okay, so basically we're looking at where oral health was prior to COVID-19. Okay, so in the Western Cape, we had the oral service plan, which was in 2010. We identified caries and gingivitis to be the most common conditions. The strategic goal here was to provide a service which allowed for promotion, prevention, to treat, monitor, and evaluate oral diseases. Okay, so the distribution which we've identified in the Western Cape, where 90% of our care was in primary health case. So that covers our area, and that the rest of it is basically tertiary or referral centers. And then recently, as a forum, prior to COVID-19, we identified that pain and sepsis management was 90% of our management. Okay, so look, it's kind of in reverse to what Dr. Potgieter was saying, but we're just doing a situation analysis prior so that we can see what type of service we're able to offer with the coronavirus being present. Okay, so with the introduction, so is the slideshow still not working?
We're on legal, regulatory, and other health declarations.
Okay, no, so it's not moving then probably.
Mhm.
Okay, so with the introduction into the Western Cape, it was on the 11th of March where we introduced our first case that was logged in by the NICD, and that was a 38-year-old male. The current situation in Western Cape, so we've been identified as an urban high-risk region. Okay, we actually have active cases of 16,000, of a total of 68,273, and many recoveries. So although we're high risk, we have been identified as having a good treatment or recovery rate. In Klipfontein, which was playing, which is specifically to the area where we're at. And once again, when we talk about a risk-based adjustment of our service, we look at how many, like Dr. Potgieter was alluding to, look at how many active cases we have. So at the moment, we've got in Western Cape, Klipfontein, we've got a total cases of 6,000 in the region where I'm working. Okay, so the implication for the oral health service. So the coronavirus, the Metro Health Service response was that they would reorganize the delivery of health service and decongesting the healthcare facilities and hospitals in order to deal with COVID-19 patients. So that is how the oral health has fallen under that part. Okay, so through that, there was a de-escalation of oral health services, and that was to assist with mitigating the coronavirus spread to patients and to staff. And eventually, we managed to devise a memo together with UWC, the University of Western Cape, which was signed in by our Chief Director, Dr. Perez, on the 23rd of March. So although we had guidance and or there wasn't much guidance, but the international bodies prior to COVID-19 arriving in the Western Cape or South Africa, we kind of never had any official documents or plans for us to be able to implement. And maybe our managers would have been a bit difficult, but because we were able to implement the memo on the 23rd of March, lots of the guidance, and because it was official, could come from there. So we could implement a plan that was official and that our line managers had to abide by. Although there was implications, we also needed to basically consider that PPE supply was still being prioritized for frontline staff when it came to healthcare. Okay, so the implications of the de-escalation was that we were only going to be providing an emergency, urgent, non-aerosol generating procedures. So our service was converted from an oral healthcare to an urgent dental care service. In specifically our substructure, we were able to identify only 4 out of the 7 units, okay, because they were identified as being sufficiently safe through the different methods of assessing the risk of mitigating the coronavirus in the workplace as being the safest and the most and accessible for the population. It also meant that the oral health staff were able to be redeployed to assist with the primary healthcare facility with the COVID-19 stream. And that guidance also came through. So basically what it's allowed us to do, it was allowed us to prepare, to plan, and to have a package that was safe and protected for our staff and for our patients alike. Part B of this, so I'm on part B now. Another slideshow isn't moving, but under part B, we're talking about what's the strategic framework that's available for us as public health workers and then public health dentists to be able to practice safely for our patients and for our. So currently, and like I mentioned, it's the long, laborious presentation, and these are the things that are available to us, and we currently have a little bit of say when we are to question management. So the occupational health and safety and the IPC guidance that is available at national and provincial levels for us as health professionals to be able to provide services to our community. Okay, so I'm just going to skip a few steps here. So under the occupational health and safety, so things that we mentioned and that are mentioned under the framework is that, so in protecting the health workers against COVID-19 and in promoting safety in the workplace, we draw on the existing OHS systems and processes that will prevent the occupational diseases in general. These may include things like staff health risk assessments and risk mitigation. Here we talk about identifying and finding ways of identifying certain hazards within our workplace and then linking them up to the risk of your complement of staff and whether that makes sense to be able to offer a certain service. Then under medical surveillance, we talk about early screening of your employees or your staff member as they enter the workplace and making sure that they are healthy as can be when they work, and if not, for the certain process to be in place for them to be examined. Further, for safety of the workplace and for patients alike. Also under occupational health and safety, there's clear guidance on the oral healthcare worker management, okay, whether the healthcare worker is asymptomatic, if they're suspected as a PUI, or whether they confirm. There's a de-isolation protocol for staff. There's guidance on the return to work of staff, and then obviously regarding everything, the education and training of staff. So we can't, to deep dive into all of them, it's even longer, but there is national and provincial guidelines which we are able to implement, whether we're in oral health or just a healthcare worker in general. Then following the occupational health and safety measures, we talk about things that are going to make work much more to mitigate SARS within the workplace. So we've got infection and prevention control measures. Under the hierarchy of controls, if you were to look at what are the different strategies which we can employ to mitigate, unfortunately, I'm not able to show the infographic, but PPE is the least effective and the last of the measures that are to be considered when we're talking about risk mitigation. So under the hierarchy of controls, they talk about first eliminating and substituting. With SARS-CoV-2, we know we can't eliminate or substitute. There's no vaccine, there's no cure. Then we talk about engineering, administrative, and PPE. So the engineering controls, and like Dr. Potgieter alluded earlier, the story about making sure that staff, that there is adequate ventilation, that there is enough spacing of patients. These are the things that are quite important prior to us even having enough PPE. And whether it's safe for us to even have a service or not will be dependent. The implementation, the framework will be the guidance, but the implementation at your clinic will differ wherever we are. So under engineering controls, just some recommendations. So, I mean, a lot of things are repetition, but making sure that there's access control at the entrance and exit with signage, okay? including the different PPE that are required at the different risk areas. Clearly marking pathways for the guided movement of patients for the points of entry into the waiting room, providing screening at the facility, ideally outside the main facility, installation of highly efficient air filtration systems, possibly if we're talking about where mechanical ventilation isn't allowed. We're talking about in high-risk areas. Yeah, and then to make sure when there's ventilation, to make sure that there's sufficient amount of air changes that are occurring. So we talk about in the guidance of air changes rates between 6 and 12 air changes per hour. There's enough guidance on how to do that. Okay, so that's under engineering control. Under administrative controls, these are the measures that are in place that it's all the paperwork and all the SOPs that we need to do to prepare ourselves so that we are as trained as can be and as prepared within the workplace to help us with decreasing the chance of spreading this virus within our workplace. Just some recommendations, making sure that there's a comprehensive workplace plan, SOPs, updating your policies, training of healthcare workers, an IPC protocol, ensuring that there's early detection and management of potentially infectious persons, making sure that there's appropriate staff to patient ratios and perhaps and the working hours to rotate staff, and then obviously some mental health and psychological support towards our staff members. Also, just to mention that the flu vaccine has been recommended, and there is even a circular where they talk about staff members being offered a flu vaccine to prevent them from getting ill with the flu virus. Okay, so the PPE, which I mentioned, which is the last part, is the most hotly contested because most of the challenges we have is around PPE. Just some considerations and from the different frameworks. So in the dental clinic, we need to employ strategies to optimize our availability of PPE. So we need to minimize the need for PPE in healthcare settings, ensure that the rationale and appropriate use of PPE, coordinate with the PPE supply chain, the principles of PPE. So we talk about making sure that there's a proper fit or seal testing to be done, especially when it comes to respirators. I know that was also something that has been quite difficult to achieve, but with line management, possibly we can have some type of guidance there. Making sure that our PPE is consistently and properly worn, that they are regularly inspected and maintained, and they are properly disposed of. The extended use of PPE, so I know there was a question regarding that. So usually PPE is discarded after a single patient or procedure. I know that the guidance that has come through is that there is possibly, especially in South Africa, maybe with the shortage, the reprocessing. And I know that UWC has at some point performed the reprocessing of the N95 respirators. But at our clinic, for example, and within our substructure, we are guided to wear it safely from WHO as well for 5 days if it doesn't get damaged or soiled. But otherwise, single disposable as far as we can. Donning and doffing of PPE, very important. And then the amount of PPE and the amount of hygiene products that's needed. I know that so when it comes to PPE, lots of our managers think and they like to base most of the decisions on what is the outcome of so it's outcome based. So if you are performing dental treatment, are you able to do so safely? And if so, are you able to offer a service? And then perhaps sufficient PPE can be appointed to the different clinics if you are able to offer a service at that clinic. Okay, so just carrying on with the different IPC, we talk about, so basically the guidelines that we have, it allows for understanding what is
Sorry,
standardized.
Dr. Mohammed,
Yeah.
could you perhaps go to the guidelines on your screen slide share? Do you have the guidelines on your screen?
Are you able to see it?
Now you'll have to exit and start the show again. I see there's 1 or 2 questions on the guidelines.
Okay, so I can share it again.
I think it's fine if you carry on like this. We can actually read it off that screen.
Okay, are you able to see the screen or not?
Yes.
Are you following with me?
No. Now you can continue.
Okay. So under IPC and part of the framework, we talk about this, what is standard transmission aerosol precautions. And standard precautions are hand hygiene, cough etiquette, visitor policy. So there's enough guidance in there and in the framework to allow us to follow it within the oral health clinic. Regarding environmental cleaning, some of the summaries just to mention is that a healthcare facility must be cleaned twice daily. The high risk areas, for example, a dental treatment surgery, that must be cleaned between patients. There's guidance on the type of cleaning materials that must be used. So these are all things that are in the framework that our managers have to abide by. And that's why taking this stance perhaps is a way of allowing them to kind of, it's a compulsory for them to follow through unless we aren't able to offer a service. Health risk, waste management, we all are familiar with that, and there is guidance on that. It's a pity that I can't show my slideshow. There are a few infographics that we are within a dental setting where we can distinguish between when it's appropriate to wear what PPE in what.
Dr. Mohammed, if you could just go out of the slideshow and do it from your desktop, maybe then people will be able to see it.
Okay, so I am.
Now that like that is fine.
Are you able to see that?
Yeah.
Are you able to see that?
Yeah, like that.
Okay, sorry for that. So in the dental setting, oh, sorry, just a bit small now. Within the dental setting, you can see what are the different PPEs that are required for when we are considering the different environmental situations that we put in. So whether we're going to be applying in a aerosol generating procedure or whether it's just for droplet precaution, and there's some PPE that's linked to that. Yeah, so that was just a summary of that. Okay, and then, okay, so part C, which is the clinical guidance. Okay, so under part A, we just had the introduction. Under part B, we had what are the IPC and occupational health and safety strategic frameworks, which are available to us at national and provincial levels. And then part C is the clinical guidance, and then just an audit report of the clinic where I'm working. So the current dental service protocol in our metro service, it's aligned with the HOD's directive. Okay, and that directive was one, to postpone elective surgery treatment at healthcare facilities, to decongest healthcare facilities and hospitals in order to focus on COVID-19. And then three is the de-escalation memorandum. Basically what this implies is that where safely possible, we are able to offer emergency and urgent oral health service to the Cape Town Metro. We've also said that a diagnosis and dental management algorithm may be utilized. So there's enough guidance from the various bodies, specifically to your area, whatever works for you as a clinician, I'm sure should be sufficient. However, it needs to be noted that any guidance used does not override the individual responsibility of the healthcare professional to make decisions appropriate to the individual patient. Under the dental management protocols that should be used and that we're currently using, we would classify it into advice and self-help, okay? And then to either identify a patient as an urgent care patient or an emergency care patient. Okay, just also to mention, so under the self-help, okay, the introduction of teledentistry during the COVID-19 pandemic, it's just some information. So the word tele means distant, and therefore teledentistry satisfies the need for social distancing, as has been advocated by the health authorities all across the globe to contain the spread of COVID virus. Teledentistry is the remote facilitating of dental care, guidance, education, or treatment via the use of information technology. Patients should be assessed for signs and symptoms of COVID-19 at the stage of telephone consultation using the latest criteria. And these are one of the strategies that we're implementing currently at the clinic where we're working to try and promote the decongesting at the service point. Part of the de-escalation of the oral health service. So currently what the memo has identified, what we treat, what we refer, and what we don't treat. And like I said, because it's official, we are able to abide by this, and our managers are able to follow through, allow us to do this, perform these treatments. And with that, you have to have a certain amount of health and safety measures in place and IPC measures in place. So what we do treat, we're treating emergency identified consultations. severe dental pain, and these are all non-aerosol generating procedures at the moment. That is what the guidance is. It's official, and that is what it has not been updated currently. Dental trauma, dental soft tissue, bacterial infection, inflammation, post-operative dental complications, and then interventions that possibly can stop disease from becoming a further greater risk or complication. Also, we are postponing or deferring any routine, elective, or non-essential dental treatment. There are a few things that we just mentioning there. So, for example, if we were to link it to some of our programs, we're not doing school health programs anymore. We have postponed it, deferred it, and then at the moment, we either delaying or referring basically any aerosol generating procedure. That is because of the different instructions, or so to speak, measures that are in place that we have to abide by, and at the same time, because of maybe not having enough information regarding to COVID-19 or not having the enough environmental control at our clinics. Okay, so just also some on the point of non-aerosol generating. So we still have a risk of producing aerosol in our workplace, even if we're performing non-aerosol generating procedures. And just some recommendations, and I'm sure it's been covered under many of the different guidance, but to use high volume suction, to have PPE, to make sure the timing of the procedures and the air changes between patients is sufficient, having forehand dentistry, which is at some point our topic, because lots of our clinics are actually understaffed when it comes to the different staff complement that we have. Dry field operating, using a rubber dam or cotton wool, to maybe use the hand scaling or hand excavating and using art techniques, placing of sutures, extraoral over intraoral x-rays, and then using a pre-procedural mouth rinse as a precaution. I've just got a lot of common oral conditions that I've mentioned, but I'm not going to go through. Like I said, the presentation was to cover quite a lot, but it's basically, I'll provide. So let's choose. So an acute apical abscess at the moment, how we'd handle it, through self-advice, urgent care, or emergency care. So these are the type of treatment algorithms or clinical effectiveness programs that we can implement at our clinics to help identify common oral disease and how to manage them. Okay, so I'll just skip that. Then also under the clinical services, the non-oral health tasks for oral healthcare workers. So during the pandemic, we were required to, many of the oral healthcare staff are required to assist with the primary healthcare, especially the COVID streams, because of them being thinly strung. The HPCSA has given an update on Ethical Rule 21, where it does mention that oral health professionals are able to perform professional acts which are outside the scope of profession, and this will be based on education, skill, and experience. And that has been implemented in our substructure and in our workplace. Many of our staff members are either swabbing, if it's a dentist. So testing, we can do contact tracing to assist. Is the community testing sites that Western Cape has pushed for, and then even policy planning and helping where they can. At the same time, it needs to be said that we need to also be sensitive to the point where once we need to reintroduce the oral health services, we need to make it known. So currently we're having staff that are even finding it difficult to go back into the oral health clinics. And that is where line management needs to not overstep, so to speak, the voluntary nature in which the oral health workers are basically assisting the COVID-19 streams. Yeah, and then returning to normal, just like Dr. Potgieter mentioned, at what point, how do we assess it, how, when, basically what we've identified as basically steps in which we can, there's no time frame. I think that it depends on many factors. But what we were mentioning was that in no particular order, a possible reintroduction would be to introduce aerosol generating procedures for emergency and urgent care, redeployment of oral staff back into the clinics, to introduce promotive and group education programs, and then lastly, to introduce routine oral health. These are all things that we need to implement once we know where we are. These are many resources that were applied, and they're all official. That's why I said it's quite a long and tedious document, but to go in and find these different aspects that are applicable to oral health within them, it is there, and we can use it to our advantage. And then the last part, I just wanted to mention the standard operating procedure. So this is now an SOP. It's a kind of a step-by-step implementation of all the different things that were mentioned now. So at my clinic, there's at the moment with 2 dentists. Through the redeployment and closing of certain clinics, there's a hygienist and dental assistant. We've identified the work, the patient flow and the staff flow through the clinic. We've identified the infrastructure so that we can try and mitigate the spread of this virus within our workplace. So as a start, so the SOP, so the first thing that we do would be screening the patients. This would be done outside preferably. The screening tool will be utilized, the current one at the moment. Here, the patients will have to wear the mandatory cloth masks and hand hygiene is performed. There's no visitor policy allowed unless it's a minor that will be accompanying, a parent that will be accompanying a minor. At the same time, we're also promoting the teledentistry or the teleconsultation. There are various official posters and signage that are placed up, and then, the outcome of a patient coming at the facility is either if they get screened negatively for COVID, they will be then referred to the dental reception, or if they positively screened for COVID-19 infection, they will be referred through the medical section. This is just a photo of how the poster that we've initiated at our clinic, which gives you enough information to be able to kind of see what services being offered, and then also the direct contact number, so that we can have an efficient teledentistry type of consultation. And then obviously the screening gets done outside the clinic. Once the first contact and if the patient is referred for dental treatment, the first contact is made with the reception or the staff member. We classify this as a standard area or clean area. Patients present to the reception as either booked or unbooked, whether they walk in or whether they are through teledentistry identified for someone to come through to the clinic. These IPC measures that are implemented there, and they all linked to the policies. There's certain PPE that are linked to the non-clinical areas. And the outcome of that would be a patient will either be seen to, or the patient will be managed through a triage, through a self-help advice, and identified as someone that doesn't need dental treatment. This is just once again photos of the entrance and the waiting area being identified as these windows that are open. We have enough space, and we've identified the 2-meter spacing between patients. Okay, and then once the patient is in the dental surgery, we've just looked at either triaging and treating the patient. So the surgery room number 1 that is used at the clinic, this can be used first as a dental triage. It's usually 1 operator, 1 assistant. Patients are allowed 1 at a time into the room. There's different IPC measures that are in place there. You can just have a look at them. The certain PPE that needs to be used, what equipment is needed, what instruments is needed, what are the different environmental controls, ventilation, making sure that the workplace is decluttered, making sure that there's functional soap dispensers, hand sanitizer, and then the protocol for examination, what to use and what not to use. And then the outcome of that would be either the patient gets triaged as someone that requires treatment, gets deferred, referred, or gets given advice. And then under the treatment surgery, at the moment, like I said, we are non-AGP emergency urgent care. Once again, it's 1 operator and 1 assistant. Certain measures are in place for that specific procedure to be carried out. Just to mention, there is a pre-rinse, and it is on government tender, the betadine, povidone, iodine, although there's not sufficient information, but it's taken as a precaution. And whether it's going to be best practice going forward, we might not know. And then the outcome of that would be to treat the patient or to refer the patient if appropriate. That would be how we'd look in the PPE if we're performing our dental treatment. Just also, like I said, lots of our line managers are also outcomes based. I'm near to the end of my presentation. So what we've done is we've identified what is the burn rate, just to try and show that there's proof and there's a need, and where our PPE and how we are using it effectively within the clinical setting and where it's going, so that possibly we can allow our managers to provide us with enough and appropriate PPE. We wish this wasn't a stance that we have to take, but sometimes we have to just show the proof, and then we might just get the compliance. So here's an example of the clinic. These are the different types of PPE, the different components of the PPE that is required. There's a predicted usage, and then for the month, we'll just calculate it and submit it, and that we can link to our stats possibly. Also regarding consumables, just a standardized form of identifying what consumables are needed, what is the predicted usage of it, and then how much at the end of the month, just a report as to how much is used. Just as an audit of my clinic recently, so when we done the emergency protocol on the level 5, that was in April basically, minimal headcount 55 with 37 needed care. Under level 4 lockdown, which was basically May, we can see that now we've introduced this, the telephone consultations and inquiries. So we weren't really measuring any indicators because our service has changed from this oral health care to urgent dental care. And so we just started looking at different ways in which we can quantify and present our work so that our managers can see that we are doing work, so to speak. And these are the techniques, once again, like I said, that speaks to them. And then we've also done a survey where we managed to see that on average, we're taking 4 to 5 minutes per patient when we are triaging them. And that's to identify whether they need just advice or medication, or if they need treatment or not. And then under dental treatment, once we're doing a non-AGP procedure, it takes about 13 to 15 minutes. And then the last slide, which is a little bit all over the show, was in July, June month, which was recently. We could see at our clinic that we had 400 inquiries. Of those, 270 were actually walk-ins. So, and then 130 were telephonic. Prior to this, lots of our telephonic consultation was not happening. I think we probably had 3 calls per week. So you can actually see, so when we're talking about redeployment of staff even, we're having a possible job creation or type of scope of practice changing of one of the workers to even manage a telephone. And this is the reality of what's going on when we're running our clinic at the moment. So we're looking at the 130 phone calls coming through for the month of June. In terms of the headcount, 188 patients actually were treated. Of those, we can see minimal were under 5, so there is still a service needed for pediatrics, but most of them were adults or over 12. And then, sorry if I can just lower that. And then of that, we could see that it translated into most of the treatment being extractions. There were actually 56 patients that could be managed just without being treated in the chair. Restorative safely with our techniques were 2. And then there were certain and mild complications and surgical procedures that needed to be performed. We just go down, okay. And then, yeah, so just as a summary or as a comment on the report and just as a finalized conclusion. So based on the Nova Park report and audit, dental triage and diagnosis protocols can be adopted from the global dental guidelines. Prescription and medications can be dispensed from as a ward stock at the dental clinic. We are currently employing that modality at the moment. So our patients do not wait at the pharmacy for long periods. Where possible, staff assist when available and in need of the COVID-19 stream at the facility, although oral health is still prioritized. PPE is accommodated thus far with the different ways in which we're approaching it. IPC measures are as provincial or national guidelines, and no AGP or non-AGP procedures being performed due to the outcome of the health risk assessments that is being done at my facility. The good about the current protocol is that it has introduced teledentistry, which is something that it's not a new concept, but it's new to our department, and possibly going forward, it could be permanent and could be of great benefit. We have improved occupational health and safety and IPC protocols. So dentistry seems to have been one of the professions where I think that IPC and OHS protocols were followed quite well. Lots of the medical and nursing are only learning these things now. Whether they were implementing it, I don't know. But I think that we can at least improve on it. But I think that we were relatively sufficient when we were doing it. There's been a strengthened relationship among oral health clinics and externally within outside into the PHC facility. By doing this, we have standardized all our services on many levels. And then within the clinic itself, we've seen that there's much more cohesion and relationship strengthening of the staff. The bad is that access to care for community there's been problematic. Not everyone is able to attend to these different clinics with limited services. We're also looking at that the morale of staff is quite low. Staff satisfaction, unfortunately, it does come with the anxiety and the fear of not doing, of getting unwell at work, and then the implications on your family. And then preventable diseases that we're previously managing through our different programs is now progressing to more severe forms of oral disease. And then the last part is that the lack of diagnosis and missed oral disease pathology, and possibly someone with oral cancer not coming to a clinic because they think that there's no service, or that they're worried about contracting the virus at our clinic when visiting the clinic. So yeah, so look, thank you for that. It was a long conversation, sorry about that. Yeah, I think that's it.
Thank you very much, Dr. Mohammed. I'm just going to apologize that we ran a bit late over time. You must just bear with us. There were some technical difficulties, but finally we did get through it in the end. I'm going to move the questions and answers to the last of the program. What I'm going to do is I'm going to ask Dr. Vova to present now. And just a reminder for participants who have raised their hand, please lower your hand and try and type the questions on the Q&A tab. If possible, then we can attend to it as a panel after Dr. Vava's presentation. Thank you. Dr. Mohammed, you can stop screen sharing. Okay, we're just getting ready with Dr. Vava's presentation.
Thank you very much, Dr. Osman. Can everybody see my slides?
You may proceed.
Hello? Hello, Dr. Osman. Can you see my slides?
Yes, you may proceed.
Yes, thank you very much. My slides are actually four slides long, so I just hope that I can keep it very brief. I won't be touching much on what has been mentioned by my colleagues, who have actually given us an in-depth and quite jam-packed presentations in as far as what we can do in our respective oral health facilities. I must, however, point out that we need to understand that the history of oral health in South Africa perhaps maybe showed itself in the presentations we just saw actually before mine, which is the Western Cape and Gauteng province have traditionally benefited from large infrastructure and knowledge investment, if one can put it like that. And obviously, those two areas and two provinces in the country have better functioning oral health systems as compared to more rural provinces, for example, like my own, which is the Eastern Cape. So I think it is very important for us to think about this and think about the impact that history plays in the current picture that we see today, and of course in the context of COVID-19. As we all know, there are of course obvious differences between rural and urban, and I won't go into much detail about those, but I want us to keep them in the back of our minds as we actually look into COVID-19, oral health, business unusual, and think about how the rest of the provinces, which are not as resourced as Gauteng, which are not as resourced as the Western Cape, are actually coping during this time. I should mention the Western Cape has one of our 4 dental institutions, academic institutions in the country, and Gauteng has 3 of these. And it would be short-sighted from us to actually expect those provinces would not have better organized oral health systems. However, the challenge is what do the other provinces do? What does the Northern Cape do during this pandemic? What does the Eastern Cape do during this pandemic? As we all understand that we have unique challenges that are very different from what one who is in Western Cape may find and what one who is in Gauteng might find. Amongst the challenges that we are facing, just to check again, Nadeem, can you see, can my slides flow? Are they moving?
Yes, they are.
Oh, lovely, thank you. There is an evident leadership vacuum in the public oral health landscape of South Africa. Our first case in South Africa was announced, I think, in March, April. But when we were looking for leadership from the national department, from our provincial structures, what most of us as healthcare providers on the ground were finding was silence, and it is still silence today. The platform that was created by SADA today, which I am very grateful and thankful for, has been a platform that has allowed us to come and engage as healthcare providers in the coalface, but unfortunately without our leadership. I heard my previous colleagues in the previous presentations mention that it is important that we are able to escalate certain issues towards management, we're able to actually talk to our HODs, we're able to actually relay certain messages. But this is not the reality in most of the other provinces, especially our rural provinces. The Eastern Cape, for example, being one of those provinces where such a leadership vacuum has made itself known and bare during this crisis. And it is very important for us to think about that and actually use this time to also reflect and really think about what are the possibilities that are presented by this crisis for us to self-introspect as the public oral health system of our country, and also as public oral health practitioners, in order for us to reimagine post this pandemic, or even during this pandemic, a different leadership structure that is much stronger, that responds much quicker to the challenges that we are experiencing. Vacancy rates, it is, I don't want to pre-assume and say it is easy for members or for colleagues in Gauteng and in the Western Cape to talk about nice, seamless systems that are able to work, because, for example, they have quite a good complement of oral health professionals working with them. That is, there's a dentist in a clinic, there will be an assistant, and if they're really lucky, they will have an oral hygienist. But in my own setting, in the Eastern Cape, the numbers of dental assistants, or rather the numbers of dentists working with dental assistants in their settings, far out, sorry, the English escapes me, but I must say that the number of dentists that we have compared to dental assistants are far more than the dental assistants that should be on duty. And during this coronavirus pandemic, what needs to happen in each setting is that we need dental assistants to be employed. We need them to be on board in order for us to be able to practice four-handed dentistry, which is one of the things that we need to implement at this time in order to prevent unnecessary infection, both to the practitioner and to the clients during the time when we are providing emergency dental care or what you have. We have a disorganized HR establishment that I will link, and I won't talk too much about that, to and refer that up to the issue of the leadership vacuum that is ever present, especially in our rural provinces. There is low PPE stock availability, and again, there is no specific directed training for oral health practitioners. I listened to my colleagues giving their beautiful presentations, mentioning that there is a need for oral health practitioners to educate themselves, to be trained in order to be able to respond effectively to the COVID pandemic. However, there aren't enough resources directed to public oral health practitioners in the country. And therefore, it becomes increasingly important that we need to create a platform, we need to create a space for us to share knowledge amongst each other and ensure that we are not left behind, especially with the knowledge with the knowledge that is currently being generated at a very fast pace from the global north. And again, one of the bigger challenges that we have faced has been the fact that we are struggling with the destruction of our referral pathways. One case in point was in my own district, 3 or 4 dental facilities closed down because either a staff within the establishment contracted the virus, and therefore the decision by senior management was that the facility, the units, everything should close down. What ended up happening was we saw an influx of walk-in patients in our regional facility. That, again, put a lot of strain in terms of what we had placed in order to be able to control to control access into the facility and to ensure that we are able to see enough patients. In fact, no, we are able to see less patients who are in need of emergency treatment. That had an implication, of course, on how much PPE we had in our stocks, and we started running through our stocks. So it is very important to understand that the current situation that we are facing is an abnormal one, and some of us, especially in rural settings, are finding ourselves in very difficult situations. One other point that I missed to place in this presentation was the issue of challenges with communication between practitioners in the coalface and their immediate management or their senior management or provincial principals. Those are the challenges that are existing in the other provinces that unfortunately have not necessarily been represented by the panelists here today. However, again, trying to speed through this, I think we need, however, to think about a way forward. We need to think about what is possible during this time, rather than to always stand and wait for our principals, who are often very slow to react, to respond to us. And I came up with a very short acronym for a kind of strategy that I have personally used in being able to respond, and that is planning is critical. However, we need to plan in a very short space of time, because unfortunately, at the rate infections are spreading and at the rate at which people are getting sick and ill, we are facing a big challenge in our public service, and therefore planning needs to happen in a very short space of time. And it becomes very difficult, of course, to plan and then have an effective plan that you've planned in a very short space of time. Definitely it is important for us to prepare and, of course, to execute on what we have basically prepared. And just going a little bit deeper into the planning, one thing that we need to consider is that each facility needs to do an individual risk assessment and a facility risk assessment. It is very important. I know it's easy for us to sit on the other side of the presentation and say that people need to do things. But the big question that most people and most practitioners have on the ground is, how do I even do an individual risk assessment? And how do I do a facility risk assessment? You are in luck, because I will tell you how to do that. Please, I would urge all health practitioners on this webinar to please visit the NICD, the National Institute of Communicable Diseases website. They have some amazing presentations there and tools to help you do an individual and a facility risk assessment. It is from that risk assessment that you are able to plan your facilities or your units' best intervention during this time. It is very important as well that we need to look at procurement, stock counting, effective communication with the community, and of course, the ongoing training of practitioners. My next slide will speak a little bit about the resources that we can access in order to be able to get a little bit of training remotely, wherever you are in the country. And of course, execution. It is very important. I think my 2 colleagues who presented before me mentioned this very much, that there is evidence out there, there is research coming out, there are guidelines that are being drafted on a daily basis by global organizations. It is important that practitioners on the ground inform themselves on a daily basis. The other thing that we need to look at is, how do we adjust our service delivery platform? Whether you're in a rural setting or whether you are in an urban setting in like the city of Cape Town, or whether you're in Johannesburg or Pretoria. It is very important that we'll have to look at things like, how do I adjust then? But this service delivery adjustment will have been informed by your individual and facility risk assessment and the outcomes from that. Of course, there are some compromises that need to be made, especially in a rural setting. We all know that our patients come from far. Our patients use their last pennies to come and access our services. Therefore, it will become very, very important that each dental team or dental practitioner exercises their best professional judgment to be able to assess those patients, not only from a clinical perspective in as far as what constitutes or does not constitute an emergency, but actually think far beyond that around things like comorbidities, the distance traveled, and the presenting, of course, clinical condition of those patients. Again, I must advocate what my colleague, Dr. Mansour, actually mentioned, teledentistry. It is not utilized enough in the public service. And I think something as simple as offering the number to the clinic, to the community, could make a huge difference in as far as controlling patient flow into our facilities, and also ensuring that indeed we see people who indeed need to be seen, as opposed to having patients coming in for a prescription of Panado and Brufen. And lastly, I think I want to mention these two things. We need to look at this pandemic also with another eye. It is an opportunity for us to advocate for the place of oral health in the healthcare service platform. Whether we are looking at it from a private sector perspective or we're looking at it from a public sector perspective. Advocacy about the role we play, what we have to offer on the table, and the need to have oral practitioners on the ground in their requisite numbers in order to be able to respond to society's unmet need. Another opportunity that has presented itself and that needs to be investigated is we need more research done by oral practitioners during this time. We need to be measuring every single thing. We need to be measuring how many people are not getting the care they need, how many people are not having access to specialized life-saving oral surgery at this time. And we also need to look at things like our patients with special needs, who are often left behind, who are often further marginalized, especially during this pandemic. And we need to think about how can we then adjust our oral health service delivery platform to both respond to those people with healthcare comorbidities and being able to ensure that we are able to treat them effectively, but also to actually respond to our clients who are also marginalized, whether or not they're marginalized based on disability or other. The last slide just speaks to some useful resources that I found quite helpful for me. You can access this wherever you are, as long as you have a smartphone and good network connection. These are websites that people can access. www.mpcconsulting.co.za, sorry, not .com, .co.za, is a great training platform. You will also get a chance to earn some CPD points while you are out there in your rural facility. And also the World Health Organization also has some amazing training platforms available for us to access more information and to be able to inform ourselves. And then of course, please follow the NICD, the National Department of Health. Definitely SADA has very useful information on their website. And also the Public Oral Health Forum, which is a network of public sector dentists. You can follow them on Facebook or Twitter. We are often sharing whatever we can find on the internet to be able to assist and help practitioners on the ground to be able to respond to their challenges. Feel free to contact SADA for advice. Feel free to contact some of the people you know are affiliated with the Public Oral Health Forum for advice. But thank you very much for lending me your ears this evening. Thank you.
Thank you, Dr. Vova. Thank you. Very, very informative presentations from all three panelists. We're going to go through the questions quickly. If the panelists could just assist me in answering these questions. A question for, I think, relevance to Western Cape. How do I refer a patient to UWC and Mitchell's Plain? Telephones don't work. What is the recommended referral pathway for patients being referred to UWC?
Okay, so currently, so at the moment, the way we're referring is we would give someone a referral letter. We do know that the services are de-escalated at UWC, and it's mostly related to the students that haven't returned yet fully. I know that we do keep in contact with the patients to try and at least follow up with them to see if they have actually been able to be assisted by UWC. Otherwise, the clinical dean, Dr. Prince, he is someone that possibly can be emailed or to find out the relevant, correct referral pathway. But we do also identify that there is shortfalls in the referral pathway prior to COVID-19 when it comes to referral pathways, including UWC, where there's Mitchell's Plain or Tygerberg. So prior to COVID-19, there were some shortfalls already. But the best would be to give a referral letter to have some type of referral register at work, keeping the patient's details, and then to possibly follow up if the telephone lines aren't working. And then there are a few email addresses of clinical managers you can possibly use.
Okay. I'm assuming that the phone question was to basically pre-arrange a referral. So as long as the patient has a referral letter, it should be fine. Is that my understanding? Thank you. The next question: what options are available in public sector to use teledentistry during the pandemic? I think Dr. Potgieter, Dr. Vova, would you like to come in on that one?
I can come in, but all I can say in as far as the opportunities that are available, something as simple as just sharing the telephone number to your facility or sharing the switchboard number with your community should suffice, especially for those of us who are working in really poorly resourced settings where you do not have sophisticated teledentistry being implemented.
Thank you.
Yeah, I think, Dr. Osman, I also think that teledentistry is something that is being underused in my experience, and we have been using it quite a lot, but we've been working on an appointment system in our clinics, and we actually do make appointments telephonically, and I agree with Dr. Vava. I used to work in a very rural district in the Northwest Province. And the problem in those areas is that the patients, they travel quite far to get to the clinics. And then sometimes when they reach the clinics, they're being told, no, the number is full for the day. And even when I worked in the central Karoo, which were also quite rural, patients would walk at 3 in the morning from their houses to get to the clinic and then being told, no, we're full for the day. So there's an expectation that's never met. So by using telephones and making telephonic appointments, the patient know if they are a little bit late at the clinic, they do have their appointment for the day, so we will see them. So I just think in terms of making appointments, even now with COVID-19, where you really certainly do not want a rush of patients to the clinic to make an appointment, because then they get overcrowded at the reception of the clinics. I think we should definitely look more into making use of teledentistry, and especially for making of appointments, which will ease the congestion at the registries at the clinics.
I think that's a very good point you raise. Now with the current situation, I know generally we try not to, some clinics don't work by appointment, but maybe this will be a good impetus, starting to get patients used to the idea of booking an appointment and actually making that appointment. It gives planning, the whole day goes much better once there is a plan of action. So you can also maybe schedule all your AGPs in one section and do your consults in the morning and then book your week through the week. So it allows for scheduling. So that is something that we can definitely implement in the clinics. The next question: what do you tell patients that phone in with pain but no swelling? Do you provide prescriptions or book dates?
Okay, so if I can, so look, just jumping onto the teledentistry as well. So there's the various components to teledentistry, and I think we're talking about booking system at the moment. So just basically tele booking or consultation on the phone. We're not talking about tele-treatment or management really. So it's that concept allows us probably to work within a safe bracket. Regarding the patient that the pain and swelling, so I think that's where we can't always ask patients to send photographs or emails of them, and it's difficult to sometimes, and the consent part around that and the management. So I think that the most important thing is the identifying how to contact the clinic, whether it's email or via a telephone number, and then through that conversation to identify, and if you can manage the patient through the phone with either self-advice or through prescription. But I think the patient at some point will still need to be informed with enough information to identify and to kind of say to themselves, when am I needed to actually go into the clinic? And if you can empower the patient with that information, the triaging algorithm that you put in place, there's various guidelines that can assist you with that. But yeah, that's from my side.
Thank you. So anybody wants to come in on the question? Basically, you cannot do any treatment without a proper diagnosis. So it's difficult to actually prescribe any medication. I think also you need to make sure you take a proper history, and recording of that would be difficult unless it's on an email or a WhatsApp conversation. But I'm sure we are innovative. Many of us, many of the practitioners out there have found innovative ways to do that. And the thing is, try and do that in your clinics as well. Try and make sure that you innovate and try and find solutions and share those solutions. Right, we're going to move on to the next one. With regards to consent. Yes, Dr. Vova, you can go ahead.
Oh, sorry. I just wanted to chip in that we should not lose really, like, from what Dr. Potgieter was talking about, the reality of many rural practitioners out there. Some of the things that we are talking about become very difficult. I mean, at this time, we understand that rural clinics become extremely busy. One single practitioner could see up to 40 people in a single day. And that's just because of the evident need that exists in rural settings. And if you're getting somebody calling in and trying to implement teledentistry from, for example, trying to consult over the phone, I think one has to weigh the risk of having the same 40 patients rocking into the facility, probably contracting the virus on their way or on their way back or at the facility and taking it back to their communities. So I think at this stage, it's very important that each individual practitioner, especially those who understand their individual clinic situation, for them to be able to feel very confident that consulting a patient over the phone, they should not be afraid to do that, especially during this pandemic. And should the patient, of course, share certain information that will then, for example, give you a suspicion that they need to come in for an assessment, then clinicians should be able to make that choice, rather than to, for example, for us to seem like we're not so sure about consulting patients over the phone. I think the HPCSA, in the guidance that it offered, does allow us some leeway to be able to do that. And I would actually urge my rural colleagues to actually take advantage of this in order to be able to respond to patients' needs.
Thank you. Very valid point you raise. And also in the rural setting, if one clinician is unsure of a certain diagnosis and he has clinical photos, obviously with the permission of the patient, he can then forward that to another colleague who's a bit more skilled in that field, and maybe that also prevents or limits the movement of that patient then being transferred to a higher facility when it could be filtered or diagnosed via colleague to colleague teledentistry. It's not only dentistry to or practitioner to patient. It could be amongst colleagues as well, as long as patient consent is always obtained and also the records keeping is meticulous. While they do allow it, you need to make sure that you have the proper records in place. All right. So then we come to now another question with regards to consent. Can we obtain consent telephonically or via an Android device to minimize the usage of stationery or usage of a pen? So I'm thinking this is just making paperless office or non-written consent obtaining. I'm not sure if many clinics are on a paperless system, but I'm sure that would have to come through the proper channels for electronic patient records. If anybody wants to come in on that.
Because I always think it's different. I'm not sure. Obviously, if you talk about electronic patient records, that's another thing. But for most clinics, I would be very reluctant to take any sort of consent over the telephone if there's no proof afterwards that there was any consent. So I appreciated that in the times we are now that you want to limit the use of stationery, but I just think at the end of the day one should cover yourself too. And in that regard, I think it is better to let the patient sign a piece of paper, because in terms of consent, obviously you're going to have to have proof that it was informed consent in the first place. So I'm always of opinion that it's better to have it in writing. That you can actually have proof afterwards that the patient did consent and agree with what you proposed for the treatment. But I guess, I mean, there are also options where people can't really write and they make process, and you take your assistant, I mean, in extreme cases, as your evidence that the patient did verbally consent to the, but I think if you can, it is better to have consent in writing.
Thank you so much, Dr. Potgieter. I'm just going to brush through the last few questions. I think we are running way over time, but I've asked attendees to just bear with us due to the technical difficulties. If there is a strong need and if they feel that we should maybe host this, we would look at some of the questions raised and maybe have another webinar for the public sector in the next coming weeks. I'm sure my panelists are willing to do that as well. Because I mean, as we go, I've learned a lot as well as we're discussing. And the thing is, networking and sharing, like Dr. Mansoor's presentation, there's a lot of stuff there that I'm sure other practitioners in the state sector or the public sector might find very informative, and empower them to also take on, or to, I would not say take on, but I would say to approach their managers with information. Okay, so we have thanks for Dr. Vova's lecture. Thank you for the presentations. This is another question. Has there been any guidance or assistance offered from National Oral Health Office to provincial oral health managers during the last 3 months? I'm not sure if we can answer that. I don't think so. We'll have to, we'll refer that back. We'll refer that back and come back with an answer. How do you handle paper filing or records in the public sector to reduce the risk of contamination? How can one protect the clerk who collects the files at the end of the day?
Dr. Osman, one thing that we've been using, and we actually haven't seen patients now in the last couple of weeks in our sub-district, but we are helping out. Some of the oral health team is helping out at the testing site, one of the COVID testing sites. And what we do at the testing site is when the folders get there, they've got 3 boxes. So the folders, after the patient was tested, the folder stays in the box for 3 days, and then only after 3 days do they take the folders out of those boxes. So they don't go to the registry directly. So obviously the clerks at the entrance to the clinic just keep note that this folder is going to lie at the COVID testing site for the next 3 days. So it's basically just got to do with it's not like again, it boils down to, it's not business as usual, it's business as unusual. The folders can't go back to the registries on the same day, in my opinion. So I know it creates a big problem at the clinic, but I think maybe if it's not a COVID positive, but if it is a symptomatic patient, then definitely I would not move that folder for 3 days.
Thank you, Dr. Potgieter. There's a request for the presentations. Dr. Vova, yes?
Oh, sorry, no, just to add, Dr. Potgieter in his earlier presentation, and I think Dr. Mansoor also actually mentioned this. At this stage, each dental facility, or rather a hospital clinic, should be screening each and every patient coming into the building or coming into the clinic area. And therefore, if patients, or rather access control, is managed at that level, concerns, for example, around file keeping and all these other things, in as far as whether it's safe to move them or not, it could be helpful to an extent, but I think also taking into consideration keeping files for 1, 2, 3 more days should not be such a big problem in most facilities, actually, and therefore ensuring that they are the virus, if it did happen to actually interact with any of those documents, dies after a number of hours, actually.
Thank you, Dr. Vova. Okay, then again, the request for presentations, we will post it on SADA's website once we have received them all. Then it's a comment, just a comment. It's important that we continue to provide health education and health promotion to patients during this period. Many practitioners may offer curative care without the preventative care. School programs have stopped, so staff should try and offer health education in dental and medical facilities if possible. This is a very valid point. We always focused on the treatment, but also prevention and oral health promotion is very important. I'm sure we can't do house to house oral health promotion, but the point is very valid. And even if just by those few clients of the clinic, if we can just educate them, I'm sure that will be making a big difference for all. But we're gonna just say answered live. Okay, we have majority of public hospitals in KwaZulu-Natal never functioned on an appointment basis prior to the pandemic. With the onset of COVID, what would the approach if 40 to 50 patients are already at the dental department by 7 a.m.? Is there a safe number of patients to treat per day? I think this will also depend on the facility's capabilities and the amount of PPE and the amount of the logistics insofar as to ensure that there is sufficient rotation of air and instruments and PPE. So it is something that even patients are going to have to get used to. And I guess this is where your dental triage, as mentioned by Dr. Mohammed, comes in, where you then look at that 40, 50 and say, these are needing urgent care, these are not so urgent, these can be delayed. So it's about management and actually managing the load. I don't know if anyone else wants to come in there.
So initially, I think lots of the metro clinics are actually looking at numbers of 40 even a day, whether it's rural or metro. I think it is evident. Lots of the clinics, when we de-escalated with the memorandum coming out, it was hit. Patients would rock up at the clinic, 40, 50 at the clinic, and the only way which we could manage was to tackle it as it came. The poster that was made with the number that was for you to be able to phone the clinic, and you kind of enforce that system where patients need to make a booking. And it was based on the spread and to mitigate and to prevent the COVID-19 spread. That was kind of what we piggybacked on. So with the changes that are there now, hopefully it needs to start somewhere. So if you were to take up that approach, maybe COVID-19 is an opportunity for you to do that. But it is difficult in the beginning. There are patients, there's lots of other considerations that you need to take into account. And I think you have to possibly take it case for case. Lots of our security at our facilities were tasked with doing with doing clinical options, and it was difficult. And luckily, we had that bit of integration with them, and they were able to assist. But it's a step that we need to take at some point if that's the system we follow. But there are a lot of challenges that come up with it.
Okay. Okay, I see we've got continued questions, just keep on coming. But I think I'm going to have to be a bit, put a stop for today at least. The questions are on the Zoom. It will be answered. What we're actually going to do, I'm going to discuss with the panelists, and then maybe we can reschedule another webinar specific around the concerns around that have been raised in the questions. Just to briefly go, it's about guidelines for elective procedures, guidelines for outreach work, oral health worker motivation. So me and the panelists are going to sit together. We're going to discuss and see how we can rearrange another webinar. I'm actually very happy that we've managed to maintain a very high attendance of over 450 attendees. And this shows that there is a big need and a big thirst for knowledge, specifically also for the public sector. So I will also take it up with SATA head office, and we will ask Casey if we can perhaps schedule another one, or maybe every once a month or something, because the interest is there, the thirst is there, and we are able to provide and meet that demand. So I'm gonna thank each and every one of the panelists, Dr. Potgieter, Dr. Mohammed, Dr. Vava, our team at head office, who has patiently, very patiently, allowed us to continue. And I'm going to thank all the attendees for attending. Thank you so much for your time. We look forward to discussing and interacting with you once again. For any queries, you can please contact the SADA head office or Dr. Met Singh. Also, that reminds me that we should also put an email address out. You can just contact her for any concerns regarding the public sector. She is the person that can assist in putting together these webinars. And also, as a last final reminder, many of our colleagues have been affected by COVID. There are few that have recovered. There are few that are still undergoing the condition, and the thought goes out to them, and our prayers are with them, and we wish them a speedy recovery. It is something that each and every one of us are going to have to maybe go through, either personally or someone that we know. The thing is, the time for us to get together and motivate each other and inform ourselves, educate ourselves so that we can better handle these things. I thank you, one and all. Have a good evening.